And thank you so much for this introduction. I'm Benedikt Höing. I'm a head physician at the clinic in Essen. And differently from the very formidable presentation of the woman before me, I will talk more about the medical part of the field due to my profession, and talk about the digital background, the use of AI in a clinical everyday life. And the background why we're dealing with it mainly in Essen is a new construction of our operations section that we got from the federal state a few years ago, and that allows us to be ahead of digitization, to be pioneers. We have a fully integrated new operating theater, and this provides us with the technical equipment to use digitized applications and also to do science. So if you think about it, there are still many clinics, and we did it until a few years ago, a document is still on paper, and they instruct the people, write the anamnesis on paper, and you have hundreds of problems. First of all, you cannot read the writing, that is one of them. And those files get lost, and you are in the operating theater, you want to operate, somebody is bad, and you cannot find their instructions. And all of that can be solved by digitization. A few years ago, the Newsweek magazine in the US did a survey finding out that worldwide most active smart hospitals are ranked in. We were not really the first one, but at the 28th position worldwide, and the number 2 in Germany behind Charité in Berlin. And we don't want to brag about it, but we were quite proud of that. The new construction of our operating section led to us being fully integrating the operating theater and the information system of the hospital. Often that's a problem that in IT you have different platforms. The database software that has the automatic result represents the automatic results. The software that provides for the instructions to the patients, and another one that has the entries in the files, and all of that leads to really not combining that, and all that could be done away with by this new construction, and we have a digital full integration. And while you're on the operating theater, for instance, you may on monitors see the relevant preoperative anamnesis, and integrate them in your operation. What is of relevance if you do a tympanoplastic or ear operation, that in between the hearing test may be consulted over and over again, or the CT or MRT anatomy evaluated there. Like, for instance, the face nerve that is at risk in certain operations, and by pressing a button the light may be modified, or laser protective lamps may be switched on to save people from eye damage, the employees from eye damage. And the AI, I'm still talking about that later. We are actively using that in order to plan operating scopes in areas that are hard to access. For instance, the boundary region between a nose and the orbiter, the eye orbiter, where it's hard to get, and you really need tools to know where exactly you need to operate. And in ear surgery, for the boundary to the skull bases. And as the person before me said, we are using an augmented reality, mixed reality or robotics, and what is really decisive, especially in our time when we've got difficulty to find up-and-coming young people, is that there is an advantage to education and science. You've got enormous problems to find qualified young doctors. And in the future, we will be successful if we are offering a good education, especially for the young colleagues. And so there are technical conditions that allow for that, because just by telling operational steps in high resolution on a monitor, a young doctor may follow that. So, because they cannot do the operations themselves from the beginning in the first years. So, back to AI, many talk about it, and the survey just showed it, but who really knows what it is? I have not understood it fully, and I'm still dealing with it, because I think you have to stay on the ball and try to define it a little bit. AI is part of information technology is automating intelligent behavior. And I wanted to find how to define that. To define intelligence is relatively difficult to break it down. It's what a being needs as a characteristic to adequately and visibly react in a certain environment. What is decisive for the medicine is machine learning. 2 weeks ago, when a Nobel Prizes were awarded, also a physicist team duo got that Nobel Prize. There's model learning algorithms that were looked into and developed, and it's very decisive in medicine. You have a lot of data, very heterogeneous, and they are on CT, MRT, and the anamnese data from the patient, who says, for 5 years I've had bad hearing. And the audiometric data, like inner ear, middle ear, impairment, and more. And you cannot just divide this data by an Excel database. You need a tool to solve problems that are too complicated than to describe them by rules, and we have a lot of data for, and that's the essence of the problem we have in medicine. The machine learning can help here to cope with this flood of data and to sort it. And always based on the fact there are technical opportunities to electronically collect this data. This is not quite serious as a heading. Many talk about it. Most of the people know what it is. I don't know what your actual individual backgrounds are, but I wanted to explain it again. Cochlear implants is really a success story, as the moderator said, of the last 30 to 40 years. A hearing prosthesis for patients whose hearing nerve is still working. Not for all patients, but patients whose nerve is still functioning, whose acoustic nerve is still functioning. So it takes up the sound that's coming in. There's a sending coil with a magnet, and the actual implant is subcutaneous, and it has an electronic girder to be a carrier to go to the cochlea, and who may stimulate the hair cells and the cochlea and the nerve directly. It's a success story of the last 35 years, and it remains the sensory organ that may completely be replaced. Colleagues for the eyes are working on retina and cornea implants, but they cannot be implanted in day-to-day business. And by the way, there are less and less mute and deaf people due to having cochlear implants. Children are getting them during the first 2 years of life. If the cognitive conditions are present and there is no other impairments, they can nearly normally hear and also go to a normal school. That's an operation in ITN, in intubation anesthetics. Takes about 90 to 120 minutes. And usually 2 to 3 nights in a hospital. The complication rate is relatively low, between 0.2 and 4%. looking into the literature, the main risks is the facial nerve paralysis, or the cranial basis meningitis, or nausea. But it's rare complications that are often not durable when they turn up. And it's a standardized intervention that is quite popular. The electrode goes into the cochlea, and one coil is behind this ear, and one is outside, and there's electromagnetic induction, so no battery exchange is necessary, and it lasts several decades as an instrument. There are some indications if there's a high degree inner ear in hearing impairment. You've got the best hearing result if you implant. The existing hearing function may still be maintained in the cochlea. I'm now talking about it later. Of course, it's the there's hardly any limits to age. There are patients that are fit to still take the anesthetics, and the understanding is may rise up to 60% of speech, the speech intelligibility, and the patients say it's much better to follow conversations, to sit in rounds with other people, especially at high environmental loudness, volume. And there are many factors that have an influence on the achieved speech intelligibility. There is anamnestic data. How long have they had hearing impairment? Has there been a trigger, like an accident? What is the cognitive situation of the patient? What is the social environment? What the audiogram, the CT, the MRT? What do they look like? All those are the most multiple data of the different different entities. There can often be more key factors, key components, but altogether we don't know how this was working together. And here AI-based machine learning help to differentiate the substrates better, and this is where our project is working at. I found this quotation of Sam Altman, the founder of OpenAI. He said, the KI will certainly lead to the end of the world. However, in the meantime, there will be certainly big enterprises, probably not that serious, and it's hard for me to really estimate what the future will be. I'm admiring the previous speaker for that, and I think it was going to play a leading more and more in a very decisive role in healthcare. What are we using as AI yet? We're using it in planning the operations, because AI-based auto-segmenting allows for preoperative planning of the operation and resection scope, and especially in oncological surgery. I've just talked about the areas that are hard to access, especially orbiter and the cranial bases are predestined for that. Operating endoscopically in the nose or in the ear, you sometimes need help of orientation. It helps, that is helped by navigation. That the preoperative CT is adapting to the position of the instrument in the operating theater. That is comparing and adjusting, and comparison to reality. So we're using, for instance, mixed reality applications that combine and interact real and virtual objects in real time, and with which the user may interact, especially in the area of teaching. And AI-based auto-segmenting gives us one example. It's a resection in the orbiter. area, a CT, an actual CAD here, for instance, at this position, and you're looking from the bottom. This is the right hand side, this is the left hand side, this is in the front, the nose, and the eye orbits, and that's the back of the head. That's the brain already. And in operations, you always want to save relevant structures, and it's sometimes hard to identify in the operating theater, am I there where I cannot go on, or can I still go on? And this is what we have, this auto-segmenting based on AI, which allows you in the operating theater to recognize autonomously the relevant structures and make them visible to the operating person on a monitor. And from these actual cuts, you may derive 3D morphs that, for instance, shows the regions to be spared, like those eyes on both sides, and where the resections of nose cavities tumors are visible. And after that, the intraoperative navigation is relevant. That's an example of a tumor that still shows a CT left and right hand side, back and the front, and we have a tumor between the nose and cavities and the ones of the eyes, and you can identify this tumor based on AI and make it visible by a 3D morph for the operating person. And as I mentioned before, with cochlear implants, you may try during the implanting to save the remaining hearing system. Here you may also use digital tools. Once the intraoperative survey or monitoring is possible of this rest during the operation, you put a headphone in the ear before the operation, and you send tones and sounds in there, and through the CI reception coil, you may find how much you need to keep. And this curve of keeping that, while looking through this oculus, the surgeon may look at this curve. For instance, when this curve is falling, they can stop and change the angle, pull the electrode back, and at least try to prevent that damage to the cochlea. And I've just said we have augmented reality in the operating theater. Now you're wondering, what is it really? This is, for instance, the virtual or augmented reality. Virtual, everybody knows from a computer game, fully digital pictures. Augmented reality, that's people using a modern car and a navigation system through a head-up display. You may have certain examples of traffic signs in the picture for the driver, and a combination of both is the mixed reality. The first one to show is the augmented reality that mainly helps the operator. If you think back to the picture with the microscope, doing an ear operation, it may take several hours, and you have to look through the oculus. So you're sitting there possibly for several hours like this. And what we can do by robotics is decoupling the eyes and the microscope. So you can sit upright all the time, and you can operate, and you don't have to put your vision down. That's a digital operation microscope, and the pictures they are taking from the operator, from the operating point are played in the eyes of the operator, and the person may remain sitting like that. That's from our operating theater. The assistant may also wear those glasses and may learn at the same time what the operator is doing at what point. And now I have a short video. I hope it will not disturb you too much. It's a video of a tumor at the ear's saliva gland, and the person is operating. It's what you see as as a surgeon, and you can have a head-up display be displayed, and the position of the robot may change. And in a high microscopic magnification, just by turning the head, you may have a change in angle. It's a great innovation by a company from Austria. I'm looking forward to see how this product is developing in the future. Another mixed reality expansion may be used in the operating theater if you put on a VR glasses and look at the resection scope in an augmented reality. And it's even more important for student classes. You may remain your study course where you've had atlases, and that's still good to have. However, with 3 dimensions, it is often good to recognize dimensions in the room. And this is the case in the VR teaching for students that can see the 3-dimensionality of areas that are hard to access, of the ear, of the central nerve system. Well, put together, it's like the can opener for AI-based innovations in a hospital. As a digital transformation seems to be found, and the CI producers are starting to offer AI tools. It looks a little bit like the traffic light goes from red to yellow, and we're not yet there. And during that phase, that initial phase of digital revolution, we would like to be there and get out those factors from our project. AI-based, we want to develop a model that already allows for the hearing, to predict the hearing outcome for the before the cochlear implant. And we would like to set up a big database that combines all the different heterogeneous data: audiometry, anamnesis, imaging, cognitive, and previous conditions, health conditions. Postoperative, intraoperative, we see from the surgeon how the intraoperative measures prove to be like, and how long is the postoperative treatment, and we just send the data to a digital infrastructure. And here we have AI-based machine learning. We want to influence, look at influential factors and conceive an algorithm that is can predict before the operation. You will certainly hear like that with the CI. If you look at your anamnesis, your CT, your mental status. And we're using 5 work packages for this. First of all of that, all the infrastructures to be acquired, collected data. Then we use methods of machine learning to assess the necessary parameters, and we develop the digital models with deep learning. And in an optimal case, and it works out to be successful, it is to be published. Of course, you can never do that alone, because we cannot do it all as physicians. As a cooperation, as for us, of the Clinic of Otorhinolaryngology with the informatics department, Hessian AI, the Artificial Intelligence Institute in Marburg. And from the DFG, fortunately, we got staff that was made available that is dealing full-time with the project. Otherwise, we could not do it besides our clinical everyday. And the goal is to integrate it more into the everyday life, to generate some awareness, to objectify the CI indicators further, and quality management. How good is our indications that we are assessing? And we need to say we're at the beginning only. The implementation has only started in the hospital. The short-term goals on our part are digital infrastructure to be used, and any kinds of prejudices should be given up, and in the midterm we want to have an objective indication based on this study also of the situation, and in the long term, of course, patient safety should be enhanced and to have a better healthcare provided in the future. So that was it on my part. I'm available for your questions. I am ready to answer. Yeah, thank you for your